because obviously the principles of surgery are going to be the same. Now I'm just going to be talking a little bit about vitrectomy. I think you've heard a lot about actual buckling surgery now, and I think it's been an age-old discussion about buckling versus vitrectomy, and in our current environment, actually vitrectomy has a lot of advantages, but at the same time, I think, particularly in our scenario, I think scleral buckling has still a major role to play. So my financial disclosures and such. So I think we're talking about rhegmatogenous retinal detachment now. Obviously, we're not talking about other forms. We've been talking about it all morning, and it just basically comes from the Greek word that refers to a breach or a retinal break. So I think these prerequisites or precursors for retinal detachment have already been mentioned, but just to reiterate, you definitely need to have a break, you need to have traction, opening up the break, you need a liquefied vitreous with fluid tracking back, causing the detachment. So I'm just going to give a bit of a historical perspective. I think there was some history mentioned already about how retinal detachment surgery came along, evolution of techniques, advantages and disadvantages of primary vitrectomy, some case selection, how do you decide what to do, and looking at a little bit about outcomes as well in terms of vitrectomy surgery for RD. So Confucius is an age-old sage telling us a little bit about history. We need to actually understand, to study our past so we know how to define our future. Really, in terms of retinal detachment surgery, I think if we know a bit about the history, and I think this image was shown earlier by Prof. Lee just now, Gonen has been really the father of retinal detachment surgery in the sense that he's the one who actually found out or proposed the theory that we all now know what causes rhegmatogenous detachment. But really he had a big difficulty at this time to actually convince his peers, because he was at that time not the main guy around, and really before Gonen, detachment had been described since 19th century. Von Graf, I think we all heard Graffi, and all the different principles of how retinal detachment was caused. A lot of the time, the big boys at the time had actually proposed that there was some sort of inflammatory condition in the choroid causing fluid buildup and subsequently the detachment, stretching of the retina, etc. And of course, the principles only came about when Gonen looked in and decided in 1904, when he moved to the 20th century, where he postulated that posterior vitreous detachment was causing traction, perpendicular traction on the retina, causing tears and subsequently allowing liquid to get in. And of course, the rest of the say is history, because that's how we understand the cause of rhegmatogenous detachment. So he did his first procedure, principles, basically based on the principles he proposed to actually locate and seal the breaks, called Igli puncture in 1920. And really these images are actually from what he had described, as you see here, how there is a break with a perpendicular traction and all the different formations of breaks that he described. And it was a very tedious procedure as it first started. Really, it involved almost some of his peers, they called him being cruel to the patient, because he spent so much time with looking in to actually find every single break. Then you have to tediously mark the meridians of the break and where they are, and subsequently use thermal cautery to actually seal the break. So from then on, in the 1930s, is when his theory started coming on and people started taking notice, because he presented a big series of cases which showed a very significant improvement in success rates to close the breaks and treat retinal detachment. And of course, from there on, then you have all these concurrent developments and improvements. From thermal cautery went on to diathermy for retinopexy, and cryotherapy had been introduced in the 30s. And subsequently, all the names that you hear of now, Charles Capens, of course, was a big thing when he designed a head-mounted indirect microscope in that time, and went on to have scleral buckling, as mentioned earlier, came about. And light photocoagulation for retinopexy was introduced as early as the 40s. First open sky vitrectomy done in 1962, and subsequently, as we know, the father of vitrectomy, as we know him to be, is Robert McNamara, and he did the first vitrectomy in 1970. So this is a video of the first vitrectomy he did, and really it was called a vitrectomy infusion suction cutter. It was a 1 probe, 17 gauge, huge instrument going to the eye. When he first did it, these were all deemed as no hope eyes, where he actually had to, of course, try out his technique. And you got this huge thing going into the eye, 17 gauge, and as you will see afterwards, the cutting efficiency as to what we know now is way, way different. So this is the cutting being done there. So Robert McNamara was credited to be the first person to actually do the first vitrectomy. And subsequently, there were developments into formation of a 3-port pars plana vitrectomy as we know now. And we need all this in our armamentarium to do a successful vitrectomy. We need a machine, we need a 3-port system, we need a good viewing system, either lens-based or wide-angle viewing as mentioned earlier. You need other ancillary instruments, your lasers, like your light sources, endoilluminations, forceps, PICs, etc. And you need a tamponade at the end to actually keep the retina in place as the break is sealed. So the principle of surgery, I think already mentioned, no different from buckling, in the sense that you have to find the breaks, you have to relieve traction, remove fluid, and you have to do retinopexy. And in addition to that, afterwards, you have to put in a tamponade. So there is positioning involved. And I mentioned earlier, one of the potential disadvantages of vitrectomy is that. So this already been mentioned by probably just now, Linkoff's rules. Again, can't stress how important it is. Well, if you're doing a buckle, you have to find all the breaks. I think similarly, we should not forget that we also need to do the pre-op examination if you're doing a vitrectomy so that we can have a better plan before we start. I think arguably if you say, oh, you could actually find all the breaks intra-op, yes, but it's always good to know what we're dealing with so you have a better plan. You don't want surprises during surgery. So what are potential advantages of vitrectomy? I think by and large the retinal people now would look at doing complex retinal detachments with vitrectomy as the prime technique, particularly giant tears. If you have significant PVR, you definitely want to do a vitrectomy. If you have posterior breaks, you have poor view of the actual breaks because of media haze, then you can actually look for the breaks better, and you can do an internal search when you do a vitrectomy, and you can eliminate the retraction with your cutter when you're doing vitrectomy. And as mentioned earlier as well, we are in the age of refractive cataract surgery, so a lot of premium IOLs doesn't mean they don't get detachments. So when you do vitrectomy, you're less likely to change their refractive error, and therefore the patient, spending thousands on that multifocal lens will not be too unhappy, hopefully. Now, why not? So there are problems as well. So I think cataract is the main issue. We do induce post-op cataract formation very commonly. You might traumatize the lens, you might ding the lens while you're operating and induce earlier development of cataract, cause retinal breaks. You need to position the patient. The patient needs to be able to position. Otherwise, it's actually going to be difficult for the operation to be successful if you can't position properly. So if you have tamponade, in the setting where you have patients coming in, either having to fly in or etc., it's difficult because they can't have gas in the eye as they go up into the air because of the potential expansion of the gas bubble and causing a significant rise in intraocular pressure. And it's expensive. It's not as economical as a scleral buckle. So there are different factors you can think about as to what will point you more towards a vitrectomy rather than a buckle. So you have to look at the eye and look at the breaks. I think all these points have already been mentioned when you select your cases. You have to find the number of breaks. Are they in the same meridian? Are they large? If they're large, they're prone to fish mouthing, so you may not want to do a buckle. And of course, where they're located, anterior, posterior. Is there any traction, any preretinal membranes? How much PVR? If there's mild PVR, you might be able to do a buckle, but if there's significant PVR with stiffening of the retina and membranes, you probably need a vitrectomy. Phakic versus pseudophakic, I think we'll show a few papers afterwards that will more or less have people veer towards buckling when it's a phakic patient, and if it's a pseudophakic patient, you're probably more likely to do a vitrectomy. Chances, because most of the time in pseudophakic eyes, when they get a detachment, a lot of the breaks will be quite anterior and small, and you might not be able to see them well. And doing an internal search during vitrectomy will help to identify everything. If you have media haze due to hemorrhage, you're definitely going to do a vitrectomy because you can't see well. And lattice degeneration, arguably associated with the detachment, you might be able to do better with a vitrectomy. Now, besides looking at the eye, you have to look at the patient as a whole. As mentioned, how old? If they're young and they have a detachment, they're probably phakic. If they're high myopes, there was a mention about the issue of inducing earlier cataract and dealing with anisometropia. And so all those are issues you have to look at. Refractive status of the eye, if they're highly myopic, if they've got thin scleras, difficult to stitch, then you might veer towards a vitrectomy. Are they able to posture? If you're able to have a patient that's well enough and you know that they have to be face down for a particular period or particular posture, you have to let the patient know, you have to inform them that that is part of the actual post-op requirements and look at that as well as a reason. Whether the patient is overseas, as I mentioned, because if you're going to actually have to put gas in, they can't fly back home, or you might have to do something else for them. And can they afford the surgery? If this is in a private setting, of course. I mean, if in the government sector, affordability is one thing. So again, personally, I think we have our own preferences as surgeons. So the skills of buckling would all revolve around the use of the binocular indirect ophthalmoscope, but less so if you're using a chandelier, obviously. There's a preference as surgeons and the availability of instrumentation for us. So all these factors will help us decide whether we're going to do a vitrectomy or buckle for this patient. So it's just a couple of videos to actually highlight what are the things that can be done. I think the steps by themselves actually will be illustrated more vividly in the wet lab. But essentially, in this is a typical patient that I would get with a detachment, middle age, high myope, and in this case it was a dense cataract with a history of floaters and blurring of vision. So it's got a large tear. I think the Amstel Dubois is useful. I don't have a pre-op image of this patient, unfortunately, but basically it was a fairly large 1 clock-hour nasal tear, macula on, and in this case we decided to do a vitrectomy purely because it was a large tear and I thought I couldn't cover it with the buckle quite well. So microincisional vitrectomy surgery will be talked about after the tea break, but in this case I use a 25 gauge system. So you want to be able to put in your trocar well, but to displace the conjunctiva, put in the trocar 3.5 to 4 millimeters behind the limbus. Usually we try to go nearer to the horizontal meridian and to give you good access either way. And these are actually valve cannulas. I think we'll talk a little bit more about the types of cannulas when we talk about microincisional vitrectomy surgery. So when you have valve cannulas, then you have less chance of leakage, and it helps to actually keep the eye firm and organized. So the first thing you would like to do is do a core vitrectomy. So you want to stay towards the center, don't move around too much. Just try and clear the vitreous in the center. And I can't see the writing here, but basically you can see over here it says core mode. So this is a Constellation machine. So you're actually having high vacuum, high cut rate. In this case, I think it's 7,500 cut. And you just clear the vitreous. You identify the break. You're going to have to usually trim the anterior edge of the break to actually relieve the traction of the vitreous there. We will usually cut off the flap there. And you go there to make sure that all the traction is relieved. So this is what I mean by relieving the traction around the break. So usually you can identify this because it's a large break. If they're smaller breaks, you want to put a bit of endodiathermy to the posterior edge to actually localize it, so when you do a fluid air exchange, you can see where the break is to treat. So in this case, it is a phakic eye. I have a chandelier put in, actually one of those 25 gauge chandeliers. To do a bit of trimming. I think you can't get too anterior because the lens is there, but just want to make sure I clear as much vitreous as I can, as close to the base as possible. So this is a little bit of indentation with a bimanual technique with the chandelier in place, 25 gauge chandelier. So here's a soft tip here. In the next step now, we are actually having done your vitrectomy, cleared all the traction, relieved the traction. You will do a fluid air exchange. So you have a soft tip there. When you first started, or when you do first start, you will realize during that moment there's a period where you do lose your view when the gas starts coming in. The important thing is to just stay where you are, not to move around too much because the view comes back as the gas forms into a full bubble. You have to go slow. You don't try to really floor your foot down, floor the pedal to try and take out the fluid as quick as possible. Go slow at first. Make sure you are actually at the brake to relieve the fluid, to remove all fluid. If you're actually moving to the center to take out fluid too quickly, then you're going to have the air bubble sealing the brake, and subsequently the fluid will track towards the macula, which will be bad in this case because it's a macon in the first place. Then you need a retinopexy with endo laser. So in this case, you can go either with a spot wise 2 or 3 rows around the brake, or do a continuous laser just to ensure you get a good coverage of the whole brake. We'll talk about this a bit later, but this is a valve cannula, so there's a little bit of venting required because there's a bit more obstruction when you get a membrane to the cannula to ensure when you're actually putting in SF6 or one of the long-acting gases to actually try and to make sure you get a good fill. So that is one case. The principles are such that you get a tamponade at the end. So a little bit more of a difficult case now. This got a younger lady, dense amblyopia with a long history of visual loss in the right eye, and it's an inferior RD. So again, Amsler Dubois, you see there's an inferior RD, there's a posterior break there, and there's a lot of retinal membrane. So vitrectomy is definitely on the cards. Similarly again, this time I decided to do a combined vitrectomy with a buckle to actually put in some support as well, which is great. In the chronic case, I tend to like to have an additional support of a 360 buckle. This is just a 240 band. And I think the principles of buckling, as mentioned earlier, I won't repeat them. So just to secure, in this case, I do most of my buckling under the scope. So this is a 23 gauge system that I'm using instead of the previous 25 gauge. As you can see, there are a lot of folds in the retina there. And when you're dealing with a more complex RD, similar principles apply. You do your core vitrectomy to clear your vitreous, identify where the breaks are, mark them. You need to relieve the traction around the break. And in this case, you have to relieve traction where all the folds in the PV are as well. So I like to use a contact lens to magnify my actual view to do the peeling. I find that it works better than the non-contact system. So you have to get in there and relieve the traction on the retina to actually ensure that the retina becomes mobile so you can actually flatten it. So usually you look for where the folds are, is where the tight folds are. You get into the creases and crevices and try to actually peel them off. There'll be a bit of mention talking about staining with the different types of adjuvants to highlight membranes. So in this case, use the perfluorocarbon liquid as well. It's important to actually try and create a bit of space for you to do some peeling and relieve more traction. And over here, this is the macular area to try and relieve the traction that you can identify membranes there. So it's a bit of a tedious job, but you have to try and identify all membranes and peel them off before you can actually get the retina flat. So having done that, you continue with your cutter. As you see afterwards, the advantages with the micro-incisional platform is the cutter actually does a lot of work for you. You can work close to the retina and delineate membranes and clear the cortical vitreous as well. After that, you put in your heavy liquid to flatten the retina, to actually create a nice flat retina before you can do your retinopexy with the laser. In this case, she had one solitary break, but she had sat on it for about 2 months, so all the PVR membranes came in. Okay, so you use oil in this instant. So I put in silicone oil after. I tend to do a fluid air exchange and then subsequently a silicone oil air exchange. I know there are some other colleagues that go straight from your fluid to silicone oil. So you have to ensure that the eye is well filled. So in this case, you see I didn't have to vent because you don't have a valve cannula. So you see the gas being vented through here, this port, as the oil is being filled. One of the tricks is actually to look at your infusion line as well. Sometimes you see the oil tracking up the infusion line, you know the eye is getting filled well. Then you just close the conch as per normally. So this is the kind of result you can get if you have to clear all the vitreous traction and flatten the retina. So this surgery is not without its complications. So one of the few key things as we start off, we cannot emphasize more the importance of where you put your infusion cannula. The worst thing you can do is to put it under the retina or in the suprachoroidal space, and you might potentially even lose the eye if you do that. So be very aware of where the lens is and make sure that you respect your circles of your hemisphere of where you're working in terms of where the lens is. And you must understand the fluidics of your machine so that you know where to actually work when you're working near the retina so that you're not going to be actually causing breaks. And how you actually put in perfluorocarbon liquid to actually tamponade the retina so that you don't get it under the retina, which could be a nightmare to get out. And of course, when you actually deal with visualization, your cornea could pack up, particularly when you're starting and taking time to do things, your epithelium will actually get edematous and your view will go. So in terms of the subretinal infusion, the first thing that you do, there's a first port that you put in. Don't turn it on until your tip is viewed, until you're very familiar and very safe and you know you're quite confident now. So sometimes, I still do it now, either you actually do a viewing of it outside the microscope with a light pipe to make sure you can see the tip, or in fact you might actually turn all your lights off to make sure you can see the tip with the light pipe before you turn it on, so that you know that you're not subretinal. If you're not sure, then come out and go somewhere else to make sure that it's better to spend more time on this step than to regret not having done it when you find that you have a subretinal cannula. So in the days of 20 gauge vitrectomy, which I have not done for must be 8 or 9 years now, doing micro-incision mainly. So we used to actually stitch the infusion in place, so that's no danger of it slipping. Whereas now, with the cannulas as you see just now, it is actually secure, but it can actually still slip out when you're manipulating the eye. So secure the actual tubing with the tape so that you don't actually get an inadvertent flicking off of the infusion during the surgery. Now, in terms of the lens, as I said, respect where the lens is. If you're doing a vitrectomy in the phakic eye, make sure you have a correct entry point where it should be. The angle of entry is opposite of what anterior segment surgery is. We try to go more anterior, then now you have to go more posterior. So you make sure when you enter, you're more vertical, so you're not going to stab the lens as you go into the eye. Avoid crossing the midline at the beginning until you're really comfortable. Now, if you do cross the midline with your instruments, try not to go too anterior to the equator because you're going to ding the lens otherwise. So remember that you're working around the lens. The lens is biconvex, so it's basically more bowed in the center. So if you're looking from the top, you can work around the edges of the center of the lens a bit more, but rather than if you go straight across it, you're more likely to actually touch the back of the lens. So remember where the lens is. As I mentioned, you know your machine settings, whether it be Constellation, whether it be any of the other machines. Before you actually get into doing vitrectomy, you need to be able to sit with your tech, understand what actually the machine does, and when you're actually stepping on the pedal, what kind of settings you need, and what is core mode and shave mode. In this case, the core mode basically means because of you can maintain your duty cycles so well with the newer machines, so you're able to remove more vitreous because the port is biased open. Shave mode is when you go nearer the retina to work with. So understand the fluidics of your machine. You can reduce your incidences of iatrogenic breaks. When you're putting in perfluorocarbon liquids, make sure you keep your cannula within the bubble as you inject. Inject slowly and don't inject too quickly. I've also had a problem when you inject, when you're too far away from the retina, you get a strong jet flying in. You can actually create breaks that way, especially when you have detached retina and you have a jet of perfluorocarbon liquid hitting the retina at a high speed. You can cause a break, and then the perfluorocarbon liquid will go behind the retina as well. So inject slowly. And if you do not have valve cannulas, you need to plug quickly when you're exchanging instruments, because when you do lose that little bit of integrity of the eye as you come out, sometimes the perfluorocarbon liquid will actually go behind the retina if you have a large break. So valve cannulas are helpful then. And visibility is everything. I think whether it be buccal or any sort of surgery, we need to be able to see what we're doing. So if your cornea is packing up, I think the anterior segment of corneal surgeon might not think the same, but I have no qualms in removing the epithelium either with a cotton bud or you just scrape it off, and that improves your view. You didn't get a job done, so don't worry too much about the cornea. So all these are complications that have been reported, either via endophthalmitis, very rare in vitrectomy, but still something to think about. Particularly in the day and age of micro-incisional vitrectomy surgery, we tend to suture less. There were early reports of wound leakage, hypotony, and potentially predisposing to endophthalmitis. Cataract formation is a given. I think when you're doing vitrectomy, you have to warn the patient. You have to be able to put it into their heads that their cataract, if they have already a cataract, they're going to get more of it quickly. If they don't, then they're likely to get it earlier. Glaucoma is one of the things that retinal surgeons will cause, either be it with silicone oil in the eye, or it could be rubeolic glaucoma, and those are very real, potential, serious consequences of our surgery. retinal detachment, you can still create new breaks, and if you're not treated, then you can cause retinal detachment. Cystic macular edema, of course, as well. So is PPV or pars plana vitrectomy really better for RD? I think the jury is out. There has been so many trials have been describing and trying to answer this question. I think the fact that we are still having both techniques used widely around the world is because there is still no good answer. So there was a randomized controlled trial that was reported over 10, 12 years ago now. This is the SPR trial, they call it, and it's a European trial with a multi-center, 45 surgeons, basically looking at scleral buckling or vitrectomy, and these are detachments of medium complexity. So it's not your simple single break anterior kind of detachments, but it's medium complexity. So it could be multiple breaks, it could be some associated lattice, and maybe a little bit of PVR. So these have been included into this study. A fairly large study, and what it essentially showed, I think the conclusions are such, have formed the basis of how we actually decide nowadays, is that in phakic eyes, as you see down right at the bottom, look at the conclusions, scleral buckle tends to give better vision improvement. This is purely because, well, not purely because, of course, the role of vitrectomy causing cataract will have a role with causing this kind of a visual problem when you use vitrectomy in phakic eyes. But when you look at pseudophakic eyes, then there is potentially a better anatomical outcome with vitrectomy. So from this study, I think it just basically shows that in phakic eyes, if it's suitable, we tend to veer towards a scleral buckle if we can. In a pseudophakic eye, we tend to use vitrectomy more. There have also been various meta-analyses because there were so many studies trying to answer this question. So some meta-analysis done have looked at pseudophakic RDs and how, again, has concurred with previous studies where vitrectomy tend to have better anatomical success. And if you look at the numbers themselves, they're not too far different, 80%, 90%. Final anatomical success is usually very high. And these are good numbers to let your patients and reassure them that you are having a problem which can be sorted out in a very highly successful manner with either vitrectomy or scleral buckle. So this was the largest study to date based trying to answer this question, but it is a retrospective study and it's a little bit unique in the sense that it looked at surgeons. It gave surveys to surgeons in 48 countries, and it was over 176 surgeons. I did contribute some cases to this study as well. And it was different in the sense it wasn't looking at anatomical success or visual success, because the fact that it was so diverse group of people self-reporting their results, so they were trying to look at a failure rate instead. And they actually classified a level 1 failure is where at the end of the study, at the end of trying everything, this patient still had a detachment, so it was classified as level 1 failure. Level 2 is when you had silicone oil in the eye and the eye was okay, and it didn't say as if you took the silicone oil out, would it still be okay? That's considered level 2. Level 3 is when they got a successful outcome after perhaps needing additional procedures to repair the detachment. So what was interesting that from this study, it did say that using a scleral buckle in uncomplicated phakic retinal detachment was a good option. So again, concurring with the SPR study, there was no real significant difference whether you did a segmental or the 360 or circumferential buckle. If it was a pseudophakic, uncomplicated retinal detachment, then you might have a better reattachment rate with vitrectomy. Again, not very much different from the SPR study, but it had very large numbers of over 4,000 patients. But they actually found that if you use a supplemental buckle, it may not be very helpful. So if you do a vitrectomy with a buckle, it may not be helpful. Now, one of the things that came out from this, they actually thought perhaps when you're actually having to do a vitrectomy and adding a scleral buckle as well, in these cases, they're perhaps already doomed to failure, because the reason you would do a combined procedure is because you're thinking this is a more complex case. So that's the problem with retrospective studies. So they actually looked at those which are more complex as well, and these more complex cases with a significant PVR, with choroidal detachment, hypotony, etc., giant tears, and they found that when you have significant PVR, then definitely vitrectomy is the way to go. You either use gas or silicone oil. And this is not different, and this is again confirming that both procedures do have a role. So essentially, I'm going to end off by just giving a little bit of a flow chart as to what I think might be useful in how you can help with your decisions on what to do when you are faced with somebody which may potentially need a retinal procedure. So if you get a tear, which is with limited fluid, very shallow, and perhaps very limited RDA anterior to the equator, potentially you can do laser still, or cryopaxy and just demarcate the area off. But if you do have something beyond that, so you have to look at the number of tears, the location, and the size of the tears, whether there's a very thin sclera, high myope, phakic or pseudophakic, if you have significant PVR, whether you can visualize the periphery or able to posture, all those terms that I mentioned, then you might think about whether you need a vitrectomy in this case, or if not, if you answer the questions along this left side of the arm, perhaps veer towards the scleral buckle. So really, I think the principles of surgery are not too different from the buckling aside. You still have to find all the breaks, you have to relieve traction, and you have to actually seal the break. I think those are Gonen's principles. So I hope to be able to tell you that whether it's a vitrectomy or a buckle, I think there's a role for both. There's no one best way of actually fixing a retinal detachment. Thank you very much.
How do you ensure your infusion is in if you have a very bad RD with choroidal detachment as well?
Yeah, those are the bad ones. I think you always try, sometimes pre-op you look and see whether, I find that in some of these cases, you might have to go a little bit more anterior to be on the safe side. And if you see a very bullous and very bad choroidal detachment, sometimes I've actually also put in an AC maintain to actually start on, to ensure that you create the space and keep the eye firm first. I think there's no hard and fast rule on how to do it when you put in your infusion. So if you do go subretinal, if you haven't turned the infusion off, then at least you have not worsened the problem. So you definitely have to look hard to make sure you see the tip before you turn it on. If you don't, keep trying different places. I'm not sure if they have a 6mm cannula for the micro incision, but I think they used to for the 20 gauge. You have a 6mm longer cannula, then you can make sure you can get through.
Six mm is available in India for 25 gauge instrumentation. For massive choroidals, do you ever drain it before going in? Like putting an AC maintainer and draining it, then going inside?
That's right. I think when you're doing micro incision, sometimes if you have massive choroidals, if you can see them and visualize where the highest point is, you can actually use a cannula to drain. So you can use a 25 gauge, go in there, and then it will just drain out, and then that helps definitely.
One more question. While doing fluid air exchange, in case of peripheral breaks with severe PVR, so sometimes the air goes behind the retina. So what you do in those kind of cases? Because it actually increases the size of the break also when air goes behind. So what are the precautions to?
I think going slow is one thing, definitely. I think when it has happened in the occasions where you end up having air, of course you have to go back to fluid and make sure you get everything out again. And if you need to, try and treat those breaks if not already treated, and perhaps try and drain from those breaks if you can. And basically going slow, I think you can still manage it, but you just have to make sure you drain slowly and ensure that your gas forms nicely so it doesn't slip underneath. Okay, I think everybody needs a little bit of refreshments. If no more questions, I think it's tea break now. Okay, tea break time. Thank you very much.